Thank you, Gianluca, and thank you to the Society for inviting me to give my thoughts and present my experience of training in minimally invasive surgery. So as we know, minimally invasive cardiac surgery has been introduced for some time now, but and whilst there has been an increase in its uptake, there's still relatively low volume in the UK and versus other European countries. For example, in Germany, up to 55% of isolated first-time mitral valve surgery is performed through a minimally invasive route versus less than 20% in the UK. And also, in terms of aortic valve disease, isolated first-time aortic valve replacement in the UK is only performed in about 12% of patients minimally invasively. So encouraging junior surgeons and surgeons in training to engage with and increase the uptake of minimally invasive surgery may help this number. What are the barriers to training? Well, I think there are a number. One is working time, and the Working Time Directive, of course, we're not strictly in the EU anymore, but working times have an impact. There are time pressures in theatre. Obviously, training in minimally invasive surgery does involve an extra time. There are consultants who are indeed still on their own learning curves, and then training someone in minimally invasive when you're already on your own learning curve may be tricky. There's, in the UK and in terms of the UK training system, there's a big focus on case numbers and having a certain number of index cases before you complete training. In terms of minimally invasive surgery, there's obviously the multiple components of the operation that have to be perfected before you move on to the next step. And as I mentioned, of course, this focus on index cases. In terms of the data available for the safety of training in minimally invasive surgery, these are publications from two centers, and whilst they're both isolated centers looking at minimally invasive aortic valve replacement and minimally invasive mitral surgery, the conclusion is that even if the operation is performed by surgeons in training, the outcomes are equal. So how do we fill the gaps? Well, of course, there's increasing the exposure during training, visiting other experienced units, attending the relevant courses and conferences, engaging with people who already have established minimally invasive programs, simulation, for example, so this high-fidelity simulators, or something low fidelity, and I think someone mentioned earlier today about making just a cardboard box and simulating a kind of minimally invasive mitral procedure. I know some centers, for example, King's, have also developed their own kind of simulation device. Of course, if you're a trainee, you can plan your rotations and make sure that you work in centers where there are already established minimally invasive programs. And then there's, of course, fellowships, which you can do either during or after your training, at the end of your training, sorry. So what's the benefit of doing a specialist surgical fellowship? Of course, it increases the specialist skills, makes you competitive on the job market when you can bring something new to the department. You spend a concentrated time of your training on a particular subspecialty. In terms of negative points, I couldn't really think of many, apart from perhaps that fellowships in different places may have varying quality. There may be some kind of financial impact in terms of your salary may be less than if you were in a different kind of job. So in terms of my own kind of journey, if you like, I got interested in minimally invasive surgery when I was still, quite early on in my career, after having seen the outcomes of patients who have undergone minimally invasive surgery. So of course, as we all do, get involved in all the subspecialties from an early stage, and I sought out opportunities wherever I could to, get involved with the minimally invasive surgery. In terms of something relatively basic, was that I learned endoscopic vein harvest. I actually introduced it in one of the units in London, and from there built upon all my experience and planned my rotations so that I gained as much experience as possible in minimally invasive surgery. After I completed my training, I was fortunate enough to be appointed to a minimally invasive cardiac surgery fellowship last year through the Guy's and St Thomas's Hospital, and also Royal Brompton and Harefield Hospital. And this was the kind of first multi-site UK minimally invasive fellowship. I was attached to surgeons who are experienced and established in minimally invasive surgery. It was a one-year fellowship, and I was essentially supernumerary, so the main focus was as much theatre time as possible. I had regular allocation in theatre, almost 5 days a week in theatre. There was a stepwise progression such that we went from the picture on the left-hand side of the screen to something on the right, something similar to what's up on the right-hand side of the screen. There was always direct supervision, and I got exposed to many different types of techniques in minimally invasive mitral surgery, for example, direct vision, and also totally endoscopic. Mini AVR, both upper hemistenotomy and right anterior thoracotomy, and then in terms of coronary revascularization, mid-cab and endo-ACAB, as well as transapical TAVI and transapical mitral valve implantation. I also got the experience of getting used to and familiar with other technologies, such as rapid deployment valves, getting used to using core knot, getting familiar with using a knot pusher, all these kind of things that are important adjuncts in minimally invasive surgery and things that may be overlooked when you want to start the program. Also, at the same time, in our unit, there was an SCP who was starting an endoscopic vein harvest, so I assisted in that. And when there was no minimally invasive surgery, of course, there's always still a lot of things going on in cardiac surgery, so I made myself available for all those things. In terms of seeing patients and working them up and making sure that they're suitable for minimally invasive surgery, I would regularly attend outpatient clinics, which I think is an important part of minimally invasive surgery and planning for patients. This was a survey on some very experienced minimal access surgeons, some of whom are in the room, and essentially half of the surgeons surveyed believed that a specific form of fellowship is required in training in minimally invasive surgery. It wasn't so clear over how long a period, but some kind of dedicated time just in minimally invasive was important. So now that I've moved on to the next step and now in kind of an early new consultant role, how do we integrate that, or how do we take all that training and put it into a role that you're now new in? There's a lot when you've just started. There's all sorts of emotions, if you like, when you in terms of your day-to-day work. But how do you then integrate that? And I think the first thing is case selection, as I've mentioned, and that comes with experience in seeing patients in clinic, knowing which ones to choose, which patients are suitable for minimally invasive, having very supportive mentors, and I've been very fortunate in that aspect. And I still do have a very supportive team, and I think this is very important when you're trying to start a minimally invasive program. When you have good team working dynamics, that obviously makes it much easier, and you feel much more comfortable in that kind of situation, such that I could then embark on performing the operation that's playing on the right-hand side of the screen. The next kind of question I wanted to pose really to the audience is, should training in minimally invasive surgery be a linear thing? Should we only train in minimally invasive after you've done 100 or 200 or 300 mitral valve repairs and then move on to minimally invasive training? Or should we perhaps start following a model that's already been established in thoracic and general surgery, for example? In thoracic surgery, it would be very unusual for you to go straight away to learn open lobectomy and then move to VATS, because VATS has become so established now, and I'm guessing the same thing will happen with robotic thoracic surgery as well. Similarly, in general surgery and cholecystectomy, I mean, you wouldn't train on doing an open cholecystectomy and then go straight to doing the laparoscopic cholecystectomy. So I think this is something that we can maybe think of as a specialty, and how best we kind of train people in minimally invasive surgery. And I think possibly the answer is to start introducing these kind of skills earlier on in the training program. I think, well, certainly for myself, I think minimally invasive surgery was actually very helpful in me gaining an understanding of techniques of, for example, in mitral valve repair, because what's happening on the mitral valve as it's being repaired is on the screen, and you can see everything that's going on. And I think this was very valuable, particularly in my training. What do we do with the patient who comes to you, the clinic? Even if you're a new consultant, says, I want minimally invasive surgery, do we still continue to offer a full sternotomy when they could be suitable for minimally invasive? So some points I thought I wanted to raise just for the future in terms of how we recognize training in minimally invasive. So for trainees, one option or one idea perhaps would be to recognize the progression in training in various components of minimally invasive surgery on the ISCP and also at the annual review in ARCPs. For example, how many femoral cannulations have you done? How many mini-access cases have you set up in that year? And some kind of formal recognition rather than just focusing on how many CABGs have been done or how many mitral valve replacements and so on, because I think we can then encourage that kind of learning during training, doing fellowships during your actual training at the same time, or working in centers where minimally invasive surgery is already established. And whether we kind of say, actually it's mandated that we acquire minimally invasive skills early in training, like EVH, VATS, and so on. So I think in conclusion, whilst obviously I'm biased, but not everyone wants to do minimally invasive surgery, and I think that's absolutely fine, but it is here to stay. And I think encouraging surgeons at an early stage during their career will increase its uptake, and so it will increase its access to patients. And I think fellowships offer an excellent way of increasing the subspecialist skills. And I think we already have some expertise in the UK, and it would be great, to nourish that and pass on the skills, if you like. So thank you very much for your attention. I just wanted to say a big thank you to the team who kind of looked after me in the last year before I was appointed as consultant during my fellowship. These are all very established and excellent minimally invasive surgeons, and I've learned a great deal from them, and I wouldn't be in the position I am without their help. Thank you.